As many of you know, millions of people are living in this country, some of them undiagnosed, with hepatitis C. And because it's Hepatitis C Awareness Month, we thought that we would highlight this condition and educate people about it, and also take the opportunity to encourage people to get tested if they haven't already done so. We have a special guest today. Joining us today is Bruce Burkett. He is the founder and executive director of the Hep C Alliance. His passion for hepatitis C advocacy came naturally as he was diagnosed with the disease in 1989. And prior to that, it was undetected for about 16 years. After 5 rounds of treatment, Bruce was finally cured. And in 1999, Mr. Burkett created the Hep C Alliance, which was formerly called the Missouri Hep C Alliance. And the aim of the organization is to crusade for hepatitis C awareness, treatment, and support. And Bruce has been very active in many positions, from serving on the boards of directors of various national advocacy groups, which include the National Hepatitis C Advisory Council, the National Viral Hepatitis Roundtable, and the National Association of Hepatitis Task Force. And he's also served as a member for the Hepatitis Fair Pricing Coalition, and I know that the expense of hepatitis C treatment medications will hopefully be something Mr. Burkett will touch on today. Mr. Burkett was even invited to the White House for the World Health Organization's World Hepatitis Day in 2011 and again in 2012. So we're really honored to have Mr. Burkett with us today, and we thank you so much for your time. Just a few housekeeping points before I pass the mic over to Mr. Burkett. If you have any questions, for those of you in the audience, you'll see in your control panel there is a bar for questions. You can type your questions in, and Mr. Burkett and I will answer them at the end of the presentation. Also, if you'd like to see this webinar again, or if you'd like to share it with somebody who couldn't join us today, we will record this webinar and put it on our webinar library page. That can be found by going to the NEDI-MEDS homepage, clicking on the Getting Started tab, and then scroll down and you'll see the webinar library page. And lastly, at the end of the presentation, Mr. Burkett will provide his contact information if you have any questions you'd like to ask him privately, or if you'd like a copy of his presentation. So without further ado, I'd like to extend a warm welcome to Mr. Burkett. And Bruce, I'm handing you the mic, and I'm making your screen live.
Okay, well, thank you very much. And I do want to thank the Addiction Technology Transfer Center Network and SAMHSA, who are also very much responsible for putting this program together. I'm actually only using a part of the program that we've actually designed for medical and behavioral health professionals. And it will be available. In addition to here, our whole program, the HCV Current, will be available online at a later date. Now, this staff was actually designed, Brian Edlin is a doctor in New York City, Diana Padella, Bess Rakowski. We're all very active in the Hep C community for many years, and their knowledge has helped us bring this program to you. Now, hepatitis C is
Bruce, I'm sorry to interrupt. Can you please change yourself to the presenter?
Oh, okay.
Mm-hmm.
Did that do it?
There you go. Gotcha.
Okay. Well, hepatitis C is actually the most common infection, bloodborne infection in this country, and it's the leading cause of cirrhosis, liver cancer, and liver transplantation. You know, right now we're having anywhere from 17 to 50,000 people die each year from hepatitis C, primarily because it's not diagnosed until it was too late. The CDC says right now at least 2.7 million Americans have Hep C, and that's a very low number. because they don't count the people that are in prisons, the homeless, the veterans, the active duty military. They're basically looking at the, well, they call it the NHANES study, but they're looking at well-employed general populations. That number may be as high as 5 to 7 million when you count all those outliers in there. And now another big group that we have are the baby boomers. You know, those of us born between 1945 and 1965, they say about 75% of us, or well, 1 in 30 of us have Hep C, and up to 75% of us don't have a clue they have it. Okay, let's see, there we go. Now, we want to really find a way to get a cure. You know, Lori mentioned how I started out back in 1989 when I was first diagnosed, and there was no cure out there. There were some treatments that we did that had interferon, lots of side effects, and about a 30% cure rate if we were lucky. And after 5 rounds, I actually was cured. But most people wouldn't do what I did through there. So we've got a vast majority of patients that have Hep C are in need of a cure. Well, I'm happy to say today we do have a cure, and I will talk about that a little later on. One of the big things we need to do as far as prevention is to train primary care providers, people that are out in the front lines who are able to see the people at risk for Hep C, learn about treating Hep C, and caring for that population. You know, there's a lot of stigma involved with hepatitis C. A lot of people think, you know, it's just a drug user's disease. Well, Hep C affects anybody, and it doesn't discriminate. And there's a lot of ways to get it besides just drug use. And we'll talk about that a little later here too as well. So we want to really work on our primary and secondary prevention. That's where we look on policy development, going out into the treatment centers, into the schools, providing education and training not only to the care workers like you are, but to our general population. Because anytime a provider sees a patient, whether it's a behavioral health provider, a social worker, you have the opportunity to educate that patient as far as what their risks are for hepatitis C. Now, if you look at the bloodborne diseases, HIV, hepatitis A, B, and C, and this little chart here kind of shows you some of the differences. You know, HIV is a lifelong infection. Once you get HIV, there is no cure. However, if you look at hepatitis A, that's not lifelong. Most people get it, they get sick, they get over it, and they're immune to it. They'll never catch it again. Now, hepatitis B in adults, you can find up to 90-95% of the people, they will get sick with hepatitis B, they'll cure themselves, and now be immune to it, so they won't catch it again. But 2 to 5% of adults will never get rid of it. And with our babies, if a baby is born to a mother with hepatitis B, unless that baby is treated immediately with the vaccination and with the human beta immunoglobulin, that baby will contract hepatitis B. Now, hepatitis C, I can't see it on my screen here, but that too is a chronic infection, but it is curable now. Now, with HIV, there's nothing that gives you any immunity as far as what protecting against getting infected again. Hepatitis A, once you get it, you'll never get it again. Hepatitis B, the same way. Hepatitis C is no. It does protect you from that exact strain, but since the hepatitis C virus is a very constant, frequent mutator, then there is no protection. Even though you've been cured like someone like me, I am still infectious or infectable. I don't have the virus, so I can't infect someone, but if I got exposed, then I could get reinfected. Now, a lot of people don't realize that hepatitis C, just like HIV and hepatitis A, is an RNA virus. And that's one of the things that helps to make it such a mutating force. The hepatitis B virus is a DNA, so it's a double-stranded nuclear virus. And again, here at the bottom, you'll see no cure for HIV, Hep A, you generally get it, you get sick, you get over it. There's a rare cure for hepatitis B for that 5% that never get rid of it. And now with hepatitis C, we can get up to over 95% cure rate. The transmission of hepatitis C, you can see we've got kind of a hierarchy here with HIV, hepatitis B, hepatitis C. All of those can be infectious with injection drugs. And that means whether they're sharing the needles, they're sharing the cottons, the cookers. You know, they've actually found the hep C virus can live outside your body for up to 6 weeks. They've actually found it in a cooker for 3 weeks after it's been cleaned out and dried. So it is very much of a risk factor. Sexual transmission, HIV, hepatitis B, that's one of the predominant forms of transmission. Whereas hepatitis C, it can be transmitted sexually, but it has to be some type of a traumatic exposure. There has to be blood-to-blood contact. Now, anal sex is very high risk for getting hepatitis C sexually. Or if a woman is on her period and has hep C, then her menses are infectious. But in a monogamous relationship, the risk of getting hep C from your partner sexually is less than 5%. I use myself as an example. I've been married 33 years tomorrow, and my wife never got it. My ex-wife I was married to in the 70s, she never got it. So unless you're having that blood-to-blood contact, it's very rare to transmit it in the household. Perinatally, mother to child with HIV is very common. Hepatitis B, unless immediate action is taken, it's very common. But with hepatitis C, there's about a 2 to 5% chance because the virus doesn't actually cross the placenta. So the transmission would actually come at birth as the baby's coming through the birth canal if the baby were to get nicked or somehow get cut. We've talked about how you get HIV. Sharing a razor, sharing a newspaper, or a toothbrush, nail clippers, those will pass Hep B, they'll pass Hep C. Same thing with open sores, cuts, anything that might have your blood on it that comes in exposure to someone else's blood, then there is a blood-to-blood transmission. Okay. Now, we think of most of our problems as being confined to the United States. We're actually pretty lucky with less than 1.7% of the Americas infected with hepatitis C. Whereas you look over here down in Southeast Asia or up in Eastern Mediterranean, 4.6. Africa, 31.9 million. We've got a lot of people spread out over the world, and they're all infected with different strains or genotypes. Most of us here in the Americas have genotype 1, and that's the most common pretty much worldwide. But we see genotypes 2, 3, 4, 5, and 6 spread around the world. They estimate 135 million people worldwide have hepatitis C, and a lot of them got them through health care. You see the big group that are in the African nation. In Egypt, actually, in 1962, they decided to eliminate a parasite. So they went around to vaccinate everybody in their country. Well, if you were rich, you got 1 syringe per family. But by the time they got down to the neighborhoods, it could be anywhere from 10 to 50 per syringe. And they infected about 25 million people back then. Now, in the United States, we're looking at up to 4 to 5 million people. And it's really hard to guess because there is no real surveillance. We can't specify and say every person in this country that has hepatitis C because there are no symptoms. And most of us have had it for anywhere from 20 to 30 years. Now, the CDC and the United States Preventive State Task Force, or USPSTF, recommends screening for Hep C for anyone that's been exposed. If they've ever been an injection drug user, even once, even 30 years ago, that's a recommended test and will be covered. Now, recently we came out with the baby boomer population, those of us born between 1945 and 1965. Both organizations have recommended that we all get tested at least once for hepatitis C. And they've deemed it such an important recommendation that there is no copayment, there is no deductible involved with getting this test to your doctor if you have insurance. If you don't have health insurance, there are avenues, organizations like my own, that we can actually get people tested for free, but that kind of varies on a state-by-state matter. Now, who do you test for Hep C? Most people, like I said, we talk about the ever injected illegal drugs, but there could be things like snorting drugs, where people put that straw up in their nose and they can break a blood vessel and get blood on that straw, pass it to someone else, they break that blood vessel. So just by snorting, that's a blood-to-blood exposure. People with HIV, they estimate anywhere from 20 to 35% of the people that have HIV are also co-infected with hepatitis C. And the cocktails are so good for treating people with HIV, they're starting to die from hepatitis C and not from AIDS. Anyone that you have come in that prevents with the symptoms, jaundice or elevated liver enzymes, should be tested. Now, a big risk, especially in the baby boomers, is if they received a blood transfusion or blood products before 1992. We named the hepatitis C test hepatitis C back in 1989, but the blood supply was not tested until July of 1992. So there's a risk factor there. Anyone that got a blood transfusion back there could have been infected and not know it. People who have hemophilia or other bleeding products, the clotting factors they used before 1987 were also infected. You're not going to find a lot of people with hemophilia born before 1987 that don't have hepatitis C and or HIV. Patients who have ever been on hemodialysis, it's gotten much better now. They are much cleaner, much safer, but unfortunately that could still be a risk for transmitting the virus. Our healthcare workers, I worked in a lab for years, and I know I had a couple of needle sticks. It's about a 5% chance if you got stuck by a needle, or if you're just working in the healthcare field or emergency medical field, that you get infected. Now, it's not in saliva or anything like that. It has to be blood-to-blood contact. Now, children that are born to a hepatitis C positive mother, there's about a 2 to 5% chance that baby will be infected. Unfortunately, you cannot test that child until they're at least 12 to 18 months old, because at that point in time they may well have their mother's antibody and it would be a false positive. So with these children, we do have to wait until they're at least 12 to 18 months old. Something that's becoming real popular these days is tattoos and body piercings. Now, if you go to a good tattoo parlor, they're bleaching everything down, they're sterilizing all the tools, they use new individual ink pots, and they do it right. We do have some homemade tattoo artists that also have the autoclaves, and they do it right. Most of them don't. If you get a tattoo while you're in prison, there's nothing safe about that. And again, we look back at our military, especially sailors. They travel around the world and they get tattoos in different ports. Even today, getting a tattoo outside the United States can be a risk for getting hepatitis C. Other groups we look at it, people in the low-income communities, homeless, incarcerated, people who have mental health conditions or substance abuse, immigrants, patients of the overrepresented groups of the ones I just listed, are all at risk. And it's not just demographic. Hepatitis C does not discriminate. It doesn't care if you're poor or you're rich or whatever. You have the same amount of risk. I don't know if many of you have heard about what happened in Indiana a few weeks ago, where they had 87 people infected with the HIV virus, sharing syringes in this one small group. Well, unfortunately, those 87 people also have hepatitis C, and if we're seeing that in West Virginia, Virginia, Tennessee, probably in your state as well, because we have so many young people that have been using the opioids, the Oxycontin and other drugs. Well, those drugs are getting more expensive, but heroin's real cheap. So people are starting to shoot up heroin now, and that causes a big increase in the infections among our youth. Sexually transmitted with Hep C among men who are infected with HIV is at a higher rate. Men who have sex with men, because of the modality of a lot of their sexual transactions, then they are more at risk of developing hepatitis C and HIV from unprotected sex. Now, the Hep C virus replicates very rapidly. You can kind of think about when you get infected with it, is it gets into your liver, gets into a virus cell, makes a copy of itself, destroys that liver cell, and now you have two. And they'll go back in, make copies, then you have 4 and the 8 and the 6. It just keeps multiplying. And this isn't actually on 1 or 2. This is going on thousands at a time. And that's what we call your viral load, or amount of virus that's in your system. Well, your liver is really great because it tries to replace every cell as it's destroyed. You can kind of think about if you cut your hand, it's going to bleed a little bit. You'll heal it and you can't tell where you got cut. Well, that's what your liver is trying to do. And if you get rid of the virus, you get rid of the drugs, you get rid of alcohol, then your liver can actually regenerate. And in my case, I went from stage 3-4 disease, with 4 being cirrhosis, to I've got a normal, healthy liver now. And that's what, not going to guarantee it happen to everybody, but it does happen. And the Hep C virus can actually live outside your body for up to 6 weeks. The HIV virus, it's about 30 seconds after it's out of your body that it's not infectious. So there's a huge disconnect between how long you can get infected by either disease. And we do not have a vaccine for hepatitis C. My screen. This is kind of looking what your liver is going through. You start off, you've got a nice, normal, healthy liver. It's nice and it's smooth. It's not swollen. That's what you want to have. Now you're slowly going to start getting some inflammation, some swelling. And actually all hepatitis is inflammation of the liver. So there's lots of different hepatitises. But as you have the damage going on over time, pretty soon you're going to start getting fibrosis. You start going to get some scar tissue going. And again, you operate fine. You don't have any symptoms. Now you're getting over here into cirrhosis, and you can see how lumpy and how discolored that liver is. The scar, which is what we call cirrhosis, it's kind of like if you kept cutting your hand over and over and over, you get that scar there and nothing goes through it. This is what happens with your liver. And when you have cirrhosis, instead of your liver filtering everything down, making your proteins, your hormones, your clotting factor, it doesn't start working right. And now this is where you're going to start getting your symptoms of having hepatitis C. You get things compensated cirrhosis or decompensated cirrhosis. And the difference is compensated cirrhosis, you've got a lot of damage, but your liver is plugging along enough that's going to keep you going. Once you hit decompensated disease, that's when you're going to start getting into liver failure. Now, most of the people that have chronic infection are going to have no problems at all. They're going to be in that early fibrosis stage. But of those people that develop chronic hepatitis, 20 to 30 of them are going to develop cirrhosis and be up here like this chunky liver there, and may die as a result of it. They may get liver cancer. Liver cancer is actually one of the fastest growing, more aggressive cancers we have right now, and most of it is as a direct result of hepatitis C. Now, you have a lot of other problems besides just the hepatitis, just the filtering. You have what they call mixed cryoglenemia, which basically is like a sickle cell anemia with African Americans. Their blood actually forms little spears and makes it very painful for it to pass, especially through your fingers. There's a lot of non-Hodgkin's lymphomas. Diabetes is a common side effect. Renal problems, your glomerulonephritis, where you're starting to have more of the renal and the kidney problems. You can have bad rashes and lesions. Your autoimmune disorders, your thrombocytopenic, which means your platelets are not working well, and you have very nonspecific diseases, chronic failure, brain fog. And taking all these by themselves, you don't think a lot about that. And this is when you're starting to get more advanced disease. I know when I started talking about some of these problems and went to my doctor, he patted me on the shoulder and told me I was getting old, get used to it. I was 32 years old then. Now, if you know someone has Hep C, you really want to keep a track of their liver enzymes. All the liver enzymes are markers of inflammation, the ALT, the AST. They can't be used as a screen to see if someone has it, because you can actually have cirrhosis and have normal liver enzymes. And about a third of the patients with Hep C have totally normal liver enzymes. Your normal range is your ALT will usually go up to about 60 and your AST up to about 40. And once they get up about 10 times that, then the doctors are going to start worrying what's going on with that liver. As you have cirrhosis, they're going to want to be looking at your bilirubin, your albumin, your platelet counts, your prothrombin time, which judges your bleeding. So they're going to keep an eye on that to see how you're progressing. The AFP, the alpha-fetoprotein test, is actually a screen for liver cancer. And if anyone has cirrhosis of the liver, they should have that screened at least every 6 months. Decompensated cirrhosis means your liver's not working. It's not processing the bile out of your system, so you find your skin is turning yellow, your eyes turn yellow. You get portal hypotension, which is then going to cause ascites. And if you kind of imagine if you ever seen someone that looks like they're about 16 months pregnant, their belly is really sticking out, but their arms and their legs are usually pretty skinny. That's generally someone with cirrhosis, and the fluid that's supposed to be filtering through the liver, instead of filtering through the liver, it goes off into the belly, and they have to go in and drain that. And it's not a one-time drain. They have to do that over and over and over until the person gets a transplant or dies. Variceal bleeding, again, is caused by that pressure. You can see your esophageal varices up along your esophagus. You can also have anal varices, and they can burst and cause internal bleeding or help you to bleed to death. Hepatic encephalopathy, I jokingly call it brain fog on steroids. Your cognitive thinking just kind of goes out the door, and you can be talking to someone and be just fine, and all of a sudden, you're just making gibberish, and that's quite often caused by the cirrhosis. Now, screening and testing for Hep C, we look at a Hep C antibody, and it can be either reactive or non-reactive. The PCR, which actually tests the amount of virus that's in your system, that can be undetected or detected, or it can have a value that goes with it, and that number could be as low as 15 or greater than 50 million. We're going to look at the antibody test here. You've got the ELISA or the chemilucents. Biggest thing about these two tests is all they detect is the antibody. They don't tell you how long you've had it or if you actually have active disease. The OraQuick is a rapid test that you can do in 20 minutes. It's just as accurate as the antibody test, and it can be done by a finger stick or a vein draw, and it takes about 20 minutes, just like an HIV rapid test. Now, if you get a non-reactive test, That means you have not been exposed to the virus within the last 3 to 6 months. There's a window period with hepatitis C. They can take actually anywhere from 12 weeks to 6 months before it will actually show up on the test. So I always tell people when they get tested, if it's not reactive, says that's great, but have you done anything in the last 3 months? And if so, then you need to be tested again. So we're talking about how they get infected. A lot of people, they think of drugs only. But we've talked about several different ways that you can get infected with Hep C besides using drugs. I mean, you get into a fist fight, sharing a razor, sharing a toothbrush. So these people need to know that these are a risk and how to protect themselves. Tattoos, if you go into a tattoo artist, most of them are very, very good. Ask them to show you their stuff. They'll be happy to show you how they sterilize and how they maintain their programs. Everyone should be vaccinated against hepatitis A. I don't care if you have hepatitis C, you've never had hepatitis C. If you haven't been vaccinated for A and B, you need to get vaccinated, but especially if you have hepatitis C. Get tested for STDs. Excuse me. Now, a reactive test means that you have been exposed to the hepatitis C virus. It doesn't tell me how long you've had it or how much damage it is. Yes, your body has seen that, and it's made an antibody, which is intended to fight that virus. If someone gets that positive or reactive antibody, I always tell them, take a deep breath. A lot of people don't realize, but 20 to 40% of the people that get exposed to the hepatitis C, they develop the antibody, are actually able to cure themselves. And the only way to know if they're in that group that cured themselves is to have the RNA test done, the viral load. Because if that comes back not detected, and it's at least 6 months after they've been exposed, then they're in that group that cured themselves. And kind of an interesting little side note, in my testing anyway, we see about 40% of young white women tend to cure themselves. All the rest of us are under 20%. Now, if you get that, until you get that RNA test, you want to assume you have Hep C. You want to avoid drinking alcohol, avoid using drugs, get your vaccinations, see a doctor to verify do you have it, and are you a candidate for getting treatment. And getting that second viral load test is really important because until you have that, you don't know where you are. Now, the RNA test, and it goes by the RNA test, the viral load, the HCV quantitative, they're all the same test, just the name is a little bit different. But they are a diagnosis of active infection. And if that viral load comes back, and like I said, it could be 16 international units or it could be 60 million, all that means is you have chronic active hepatitis C. Your genotype, which is a subtype, and with Hep C, there's actually 7 known genotypes now. Number 7 was just found last year. Most of us have genotype 1. And a way to think about a genotype is you think about a poodle. You've got a standard bred poodle, and then you have a toy poodle, a miniature poodle, a little bitty poodle, and a toy box poodle. They're all poodles, but they're all different. That's what a genotype is. And your genotype is important to see which treatment you're going to have to take. Most of the new treatments they're looking at now are aimed at genotype 1, either 1A or 1B. One treatment works better on 1A, one works better on 1B. So there's a lot of variety there. Now this is the CDC's hierarchy of how someone should get tested. You start off here, if they get tested, it's negative, there's no antibody, you don't have to continue screening, but you need to do education there. If it's positive, they're going to look for the RNA test. Is it there? No. It looks like you may have cured yourself. If it's positive, then you see over here that it's detected, you have current disease, and you want access into care. The things that are really going to progress someone with hepatitis C is drinking alcohol. And if they know they have hep C, that's the first and most step, and often the hardest step is to quit drinking alcohol. And if you've got someone that's a long-term hardcore alcoholic, it's hard to say, you got to quit drinking. If they can slow down drinking for a start, that can help. If they have HIV, that's going to accelerate the expansion of the disease. The older we are at the time we get infected, people get infected in their teens and 20s are going to live a lot longer than those of us who get infected in our 40s or our 50s. Men are more likely to progress faster. If you have diabetes or insulin resistance, that too can increase the rate that you're going to progress. You can also get what we call a fatty liver disease, steatohepatitis, and that is a disease that we're seeing more and more in this country, largely because of our diet. So in the fatty liver disease, you've got the alcoholic, the non-alcoholic, and then hepatitis C genotype 3 is also much faster progressing. Now, anyone with hep C, we want to recommend they get vaccinated for A and B. We want to educate them about transmission and strategies to resist their transmission, and to clinically evaluate them. Are they ready for treatment? Are they a candidate? In those, again, they're going to look at your liver enzymes, your liver function tests, the bilirubin, the albumin, the platelet count. They're going to want to see how much fibrosis you have or scarring in the liver. And that can be done with a biopsy, or they can do a test called a FibroSure or a FibroScan. And the FibroSure and the FibroScan are non-invasive types of program that can show you how much damage has been done. The damage is important to know, especially with the cost of the new drugs. A lot of the insurance companies and the Medicaids and the Medicares are requiring that the patient have stage 3 or stage 4 damage before they're going to pay for the new treatment. Now, if you have hepatitis C, as I mentioned earlier, they need to have that alpha-fetoprotein test done every 6 months. And it's also a good idea to have the hepatic ultrasound done as well, because that's going to give them a little better picture of what's going on. Now, who gets treated? I think everybody should get treated. The CDC agrees with me and the American Association for the Study of Liver Disease, but we can't treat everybody. So we got to look at how much damage they've had. Are they having other extrahepatic manifestations, the cryoglobulinemia I talked, or the ascites and other problems? Does the patient want to get treated? If they're on HIV medications, are there drug-to-drug interactions? Do they have HIV, or are there some other serious diseases that you need to look at in conjunction with the hepatitis C? For example, if someone has autoimmune hepatitis and hepatitis C, you can't just go in and treat the hepatitis C without causing problems to the autoimmune, or vice versa. And then also, are they going to take the medications? It's not as big of a case now with the better drugs, but with the earlier drugs, that was a real problem. People actually taking the medication, because every time they took a shot or a pill, they got sick. The insurance coverages. Again, I mentioned that because Medicaid, with the expense of the drugs, are requiring more extensive disease states before they'll actually treat someone. And I don't agree with that, but we do have to look at their priorities of care. And the people that have earlier disease do have a little longer to go before they needed treatment. Now, genotype 1 is the most common. It used to be the interferon and ribavirin. I actually got cured before that combination came out. Then they came out with bocephonir and talapivir, which were polymerase inhibitors, and they were also given with the interferon and the ribavirin. Now each step here, this had about a 30% cure rate. Here we're seeing a 40 to 50% cure rate. Then in 13, Sempavir or Olysio came out. And right after that, Sovaldi came out. These two drugs here, either together or alone, were greatly increased the cure rate. And they also greatly increased the price of the medications. Today, last October, they came out with Harvoni. 1 pill a day, no shots, no ribavirin. The treatment goes anywhere from 8 weeks to 24 weeks, depending if someone has cirrhosis or if they've been on treatment before. So, soft SIM, they call this, and it's a combination of Sofosbuvir and Sempavir. It's got about a 92% cure rate, but it's very expensive and was just recently approved. Then you have the Vicura Pack. And the Vicura Pack is 3 pills in the morning, 2 at night, generally for 12 weeks. And that and the Harvoni both have a cure rate anywhere between 92 and 99%. So they've gotten extremely effective and without the side effects. Now, when we put someone on treatment, we look at what their viral load is before they started treatment. And then 12 weeks after they finish, they're going to look at that again. And if that viral load comes back not detected, that's when you raise up and cheer, because that's what we call a sustained viral response or a cure. That means no virus is there. It's gone. By getting rid of the virus, you're going to reduce the number of liver failures we're going to see. That can reduce the number of liver cancer and liver-related deaths. And a big part of this has come about because of the oral therapies that they've just come out with. And because there's no side effects, they're much more treatable. Now, we talked a couple of times about who should get treated, what the cost of the treatment is. The virus or the liver stage, they stage your damage from stage 1, which is pretty much just a little bit of damage, to stage 4, where it's cirrhosis. Those between stage 3 and stage 4 need to be treated right away. Liver transplant recipients, people that are having complications because of their Hep C, are the priorities to get treated. Right now, the Medicaid are saying F3. Some of the insurance companies are backing that down to stage F2, where they've got a little bit more damage going on, but it's not extensive yet. And as with anything, the earlier you catch it, the better your cure rates, the better the people are going to be. Now, transmission, if someone knows that they have Hep C, they need to change their lifestyle. And that's a very important meeting that they have to have, because they can't expose it without realizing it. Now, treatment, if we were to treat anybody that had Hep C whose life expectancy was at least a year, that's a win-win situation. And the AASLD came out and said in big quotes at their last meeting, payers should not deny treatment to anybody. And that doesn't matter whether they're an IV drug user, they're, whatever their condition is. If they have Hep C, they should be able to be treated. Here's a priority chart showing where we're going to look at. The advanced fibrosis, if they're transplant patients, if they're having the extrahepatic manifestations, the cryoglobulinemia or nephritics or kidney problems, they're at a higher level of need to get treated today. Now, if you have stage F2, if you have HIV or hepatitis B, they need to get up there. Other liver diseases like non-alcoholic steatohepatitis can also push them to the top. The debilitating fatigue, by the time you're getting to having stage 3, that's where you see that. If they have diabetes or the skin rashes, all those are areas that should put them a little higher up on the ladder as far as getting treated. Excuse me. My allergies. This is kind of a comparison of a couple of the treatments. The LDV soft is Harvoni, the 3D is Vicurapac. And you can see with someone who's never been treated before, they're looking at, with no cirrhosis, close to 100% cure rate. If they have cirrhosis, it's still 90% or greater that they're able to cure these patients. Now, people have experienced treatments. That would mean someone who has gone through one of the earlier treatments and either relapsed or it didn't work or whatever. These people are as well able to come along with the various treatments. The SimSoft is the combination of the Sempavir and Cefusibur, and the Vicurapac, they're both about 95%. The Harvoni with cirrhosis is almost 100% for 24 weeks treatment. The Vicurapac is about 97%. So there's a very high cure rate, whether someone has cirrhosis, whether they've been treated or not before. I mean, it's a whole new world as far as treating this disease. I'm going to skip this here. Some of the resources, I've kind of flown through a lot of these things. Some resources that you can go to, the Caring Ambassadors Program, and they actually have a program called Advocates United, where they're working with people like you and me to try to get us better educated and working with our government officials and trying to change some of these regulations. The National Viral Hepatitis Roundtable is made up of about 240 different organizations, both nonprofit and corporate, working to fight the battle against hepatitis C. Help for Hep is a toll-free help assistance line for anybody with hepatitis C. It's actually manned by people like myself we've been there, done that, and got lots of t-shirts. So we're able to try to give some peer-to-peer support. If you want to go to a web page that has everything you want to know about hepatitis C in an unbiased, factual basis, that's the HCV Advocate. And that's at hcvadvocate.org. That's the main site I recommend anybody to go to. The American Liver Foundation is there. You can look for the hepatitis C guidelines. The CDC has a great page called cdc.gov/hepatitis, and that's going to give you everything you want to know about hepatitis A, B, and C, and D, because we do also have hepatitis D out there as well. The Veterans has a good website to give veterans information. And any resources that we can give you to help you help your patients, please let us know. I'm located in Columbia, Missouri, but we do work out nationwide. And if any of you have any questions or if you want to call and talk, send me an email. I'm more than happy to listen and help you any way that I can. Do we have any questions?
Thank you, Bruce. That was a wonderful presentation. It was really informative. I think, yeah, let's open the floor for questions. I see we have a few here. Let me just scroll through them and I'll read them. This is a question from Silvana. She asks, you mentioned that for people born between 1945 and 1965, that they are at an increased risk. Does this apply worldwide or only to people born in the United States?
I'm not sure about worldwide, quite possibly. The data that we see is out of the United States. The baby boomers, you look back in the 60s and 70s days of drug, sex, and rock and roll, and if you were there, there was a risk of that. Not necessary if you did drugs. You could go to a dentist back in the 60s and 70s and not have good sterilization products. So we just didn't know anything about hepatitis C at that time. And our blood supply, if you got a transfusion in 1960 or 1968 or 1988, there's a risk that you got hepatitis C from that blood transfusion. and that's why we really advocate to get tested at least once.
Okay. We have a couple of questions from Samuel. He asks, what, if anything, is the Hep C Alliance doing to advocate for lowering the cost of expensive medications like Sovaldi or Havoni? And do you help people pay for those medications?
That's a great question. Great question. I've been partnerships with the Hepatitis Appropriations Partnership and the Fair Pricing Coalition for many years, trying to get the companies to come down in price. When Sovaldi first came out, it was priced at $1,000 a pill. Harvoni came out at $97,000 for that 12-week of treatment. Then Vicuripac came out, and their price was $83,000. But that started an avalanche. All the prices are now about 40% less through contracts they've made with Medicaid, Express Scripts, CVS pharmacies. So the prices have come way down. And we also work with patient assistance programs that if you have a patient that needs treatment, if they have insurance but they can't pay their copayment or the deductible, there's avenues that they can help get that paid. In fact, Needy Meds has those sources. If someone does not have any insurance, they can't get Medicare, they can't get insurance, the assistance programs will also help them get the medications free. And then they have to pay for their doctors and for their lab work. But those, again, you can find those sites through the Needy Meds. Our alliance itself, we try to help you find these resources. I don't have funds to help you get into treatment. I wish I did, but that's a whole nother ballgame. What we do is we provide education and low-cost testing. And if that's a need, then we can help you with that. Just feel free to give me a call or an email.
Thank you. And Sam has a follow-up question. He asks, does the World Health Organization, if they add these medicines, these expensive medicines, to their essential medicines list, will that affect the price, or do you know anything about that?
Definitely a price affects it overseas. I know several companies, Gilead in particular, has made contract arrangements with the governments in India, Pakistan, Egypt, and a whole handful of other companies where they're actually pricing this treatment out about $300 a month. As far as essential medicines, trying to get them cheaper to those countries. Hepatitis C is a big focus with the World Health Organization, and kind of as a splinter with that is the World Hepatitis Alliance, which is a worldwide network of advocates and scientists trying to work towards solving this problem. And they can be found at...
Oh, I'm sorry. I was going to ask...
Go ahead.
I'm sorry, Mr. Burkett. I was going to ask, have there been efforts in this country to advocate breaking the patent on the Hep C medications to bring down the cost? I know there's been a lot of controversy about the expense of these medications.
There is a lot of controversy. There has been talk in Congress about using the VA to break that. I don't know where that's going to go. Mm-hmm. That's kind of a pay grade above what I'm at. My advocate would be, and suggestion to everybody here, is call your congressman, call your senator. We do have legislation pending in both the House and the Senate for the Hepatitis C Education, or Viral Hepatitis Education and Testing Act, which would provide funds to provide education and testing on a nationwide basis. The president put an additional $62 million in his budget for the CDC's Department of Viral Hepatitis. There's also $31 million in the VA budget aimed just at treating hepatitis C. So these are all areas that if every one of you picked up the phone and called your congressman and your senator, and express concern about this, that's how we're going to get action done.
And last question, Sheila's asking how can she obtain a copy of your slides? Should she email you?
Yes, just send me an email. It's bruce@hepcalliance.org.
Okay. And with that, I want to just demonstrate a few resources for hepatitis C on the Needy Meds website. So just bear with me for one moment as I switch the screen. Okay, so here's the Needy Meds homepage. This is needymeds.org. Let me just enlarge this. So if you're looking for assistance with the cost of your medications, we have a prescription assistance section here on the patient savings tab. And you can search for a brand name medicine or a generic name medicine. And if we have more than one prescription assistance application for a particular medicine, the ones that provide the greatest financial assistance will be listed at the top of the list, and the ones that provide lesser assistance will be toward the bottom of the list. So you can look, for example, for, let's just say, interferon. So you would click on generic and then scroll down, and you see there are PAPs for interferon alpha 1, alpha 2A, alpha 2B, and so on. And you can look for other medications as well. Over here where it says free low-cost sliding scale clinics, if you click on medical clinics and you look for clinics in your state, in the column that describes the services provided, it will tell you if that clinic provides hepatitis C testing, and sometimes some of them will also provide treatment, so that will be noted there as well. In the coupons and rebates section, you can search for a category. If you click there and then click on hepatitis, you'll see we have a number of coupons and rebates related to medications and supplies for people living with hepatitis. You can also search by diagnosis for disease-based assistance. Disease-based assistance will largely be for things other than medications, although you may find a few injectables in this section. But if you click on H and then scroll down, you'll see we have hepatitis B and hepatitis C. So if I click on hepatitis C, I'll pull up programs that will help people, in this case, pay for insurance co-payments or for the cost of medications, travel expenses, meals, testing, and so on. So that's another tool that might be useful to you as well. And as Mr. Burkett mentioned, Needy Meds is a clearinghouse of information about patient assistance resources, not just for hepatitis C, but for all kinds of medications, medical expenses, and so on. If there's anything we can do to help you, let me just give you my contact information as well. This is my email address. If you have any questions, you can contact Lori at needymeds.org. If you'd like us to mail you Needy Meds drug discount cards, there's never a charge for that, and you can email my coworker, Deb, at needymeds.org. If you or your patients need assistance finding resources, finding programs, if you're having trouble with the website, please call our toll-free helpline. We have English and Spanish-speaking operators, and they're there Monday through Friday, 9 to 5. And again, we thank you so much for joining us today, and thank you so much, Mr. Burkett, for your time. Thank you for sharing your story with us. Thank you for telling us about your experience with hepatitis C. And it's certainly admirable how you used your diagnosis as the impetus to change other people's lives, to educate other people, to encourage other people to get tested and get treated. And thank you so much for being inspirational and an advocate for other people. And we thank you so much for sharing the resources of the Hep C Alliance with us today. And again, if you have any questions for Mr. Burkett, you can feel free to email him after this presentation. And again, this presentation is recorded, and it will be on the Needy Meds webinar library page in the next few days. So thank you so much for your time. Thanks for joining us today. The next overview webinar for NeedyMeds will be held June 18th, and that is on the website right now if you'd like to sign up for it and learn more about NeedyMeds resources. Until we meet again, we wish you happy days and good health. Take care.
Thank you, Lori.
Thank you, Mr. Burkett. Take care.